Hi, today I will be talking about treatment for atrial fibrillation. American College of Cardiology, American Heart Association guidelines on the management of atrial fibrillation was updated recently in 2023. Atrial fibrillation is the most common arrhythmia. The new guideline recognizes atrial fibrillation in 4 stages. 1. At risk for atrial fibrillation. These are the people who have risk factors such as obesity, alcohol consumption, hypertension, diabetes, and hyperthyroidism. 2. Pre-atrial fibrillation. These are the people who have structural findings such as mitral stenosis. 3. Paroxysmal and persistent atrial fibrillation. 4. Permanent atrial fibrillation. Treatment of atrial fibrillation falls under 3 main categories. 1. Anticoagulation. 2. Rhythm control. 3. Rate control. Anticoagulation. Anticoagulant therapy reduces the risk of thromboembolic stroke in patients with atrial fibrillation. The decision to use an oral anticoagulant in patients with non-valvular atrial fibrillation, i.e. those without moderate to severe mitral stenosis or a mechanical heart valve, is based on clinical risk scoring system such as CHA2DS2-VASc score. Treatment with an oral anticoagulant is generally recommended for men with a score of 2 or greater and women with a score of 3 or greater. CHA2DS2-VASc scoring consists of heart failure 1 point, hypertension 1 point, age greater than 75 years 2 points, diabetes mellitus 1 point, stroke or transient ischemic attack 2 points, vascular disease 1 point, age 65 to 74 years 1 point, and female gender 1 point. Total score of 10. Patients with atrial fibrillation who have a moderate to severe mitral stenosis or a mechanical heart valve should be anticoagulated with warfarin. Choice of anticoagulant. Direct oral anticoagulants, also known as DOACs, are recommended over warfarin for patients with non-valvular AFib, including those with bioprosthetic heart valve. Warfarin. It inhibits the synthesis of clotting factors 2, 7, 9 and 10. Dosing. It is given in a dose of 2 to 10 mg once daily. Warfarin requires close monitoring and dose adjustment to keep the INR between 2 and 3. INR is measured weekly during the initial treatment and thereafter once monthly. Dosing algorithms are available at warfarindosing.org. Drug interactions. Warfarin has multiple drug interactions. Co-administration of amiodarone significantly increases warfarin's anticoagulant effect. Warfarin also has interactions with vitamin K containing foods, most notably green leafy vegetables. Reversibility. Vitamin K can reverse the anticoagulant effect of warfarin. Patients taking warfarin who have life-threatening bleeding should receive IV vitamin K along with 4-factor prothrombin complex concentrate. Some advantages of warfarin. It has a long history of clinical experience. It is given once daily. Vitamin K can reverse the anticoagulant effect. Established method for determining the extent of anticoagulation by measuring INR. Some disadvantages. There's a higher instance of intracranial bleeding compared to direct oral anticoagulants. Frequent INR monitoring is required. It has numerous drug interactions and comes with dietary restrictions. Dabigatran, brand name Pradaxa. In the RELY trial, dabigatran 150 mg twice daily was found to be superior to warfarin in preventing both ischemic and hemorrhagic stroke. The risk of intracranial bleeding was lower with dabigatran compared to warfarin, but the risk of major GI bleeding was higher with dabigatran. Dosing. Dabigatran is given in a dose of 150 mg twice daily. It is primarily eliminated by kidneys. Dose adjustment is recommended in patients with renal impairment with creatinine clearance less than 30 ml per minute. Drug interactions. Dabigatran is a substrate of P-glycoprotein. Inducers of P-glycoprotein such as rifampin can reduce the level of dabigatran, and inhibitors such as ketoconazole can increase the serum concentration. Reversibility. Idarucizumab, brand name Praxbind, is FDA approved to reverse the anticoagulant effect of dabigatran in the event of life-threatening bleeding. Rivaroxaban, brand name Xarelto. In the ROCKET AF trial, rivaroxaban 20 mg once daily was found to be non-inferior to warfarin in preventing stroke, but it did not achieve superiority over warfarin. Patients taking rivaroxaban had lower rate of intracranial bleeding and fatal bleeding, but noted to have higher rate of major GI bleed compared to warfarin. Dosing. Rivaroxaban is given in a dose of 20 mg once daily. It should not be used in patients with moderate or severe hepatic impairment, Child-Pugh B or C classification. Dose adjustment is recommended in patients with creatinine clearance less than 50 ml per minute. Drug interactions. Rivaroxaban is a substrate of P-glycoprotein. Inducers of P-glycoprotein can decrease the level of rivaroxaban, and inhibitors of P-glycoprotein can elevate the level of rivaroxaban. Reversibility. Andexanet alpha, brand name Andexa, is a recombinant human factor 10A analog which is FDA approved to reverse the anticoagulant effect of rivaroxaban in the event of life-threatening bleeding. Apixaban, brand name Eliquis. In the Aristotle trial, apixaban 5 mg twice daily was found to be superior to warfarin in preventing stroke. It was noted to have less major bleeding compared to warfarin. Dosing. Apixaban is given in a dose of 5 mg twice daily. It should not be used in patients with severe hepatic impairment, Child-Pugh C classification. The dose of apixaban should be reduced to 2.5 mg twice daily in patients who have more than two of the following: age greater than 80 years, body weight less than 60 kgs, or serum creatinine greater than 1.5 mg per deciliter. Reversibility. Andexanet alpha, brand name Andexa, is FDA approved to reverse the anticoagulant effect of apixaban in the event of life-threatening bleeding. 4-factor prothrombin complex concentrate is an alternative. Edoxaban, brand name Savesa. In the Engage AF TME trial, edoxaban 60 mg once daily was found to be non-inferior to warfarin in preventing stroke and had significantly low rate of major bleeding. Dosing. Edoxaban is given in a dose of 60 mg once daily. It is 50% renally excreted and is not recommended in patients who have creatinine clearance less than 15 ml per minute or who are on dialysis. It should also not be used in patients who have creatinine clearance greater than 90 ml per minute. Reversibility. There is no FDA approved reversible agent for edoxaban. Some advantages of direct oral anticoagulants. There is a lower rate of ischemic and hemorrhagic stroke with DOACs compared to warfarin. Lower rate of intracranial bleeding compared to warfarin. Does not require frequent INR monitoring. Reversible agent in the form of Praxbind and Andexa available for DOACs except for edoxaban. Disadvantages. There is a higher rate of major GI bleeding with all DOACs compared to warfarin. There is no established method of determining the extent of anticoagulation. Dose adjustment is required for renal impairment. Rivaroxaban and apixaban should not be used in patients with hepatic impairment. Interruption of anticoagulants. Guidelines recommend stopping warfarin for 5 days before an elective surgical procedure. Guidelines recommend stopping dabigatran between 2 to 4 days before an elective surgical procedure. And for factor 10A inhibitors, it is recommended to stop 1 to 2 days before an elective surgical procedure. Rhythm control. The updated 2023 American College of Cardiology, American Heart Association guidelines for atrial fibrillation emphasizes early rhythm control. The treatment of choice for urgent conversion of symptomatic unstable atrial fibrillation is DC cardioversion. Radiofrequency catheter ablation is now considered the first-line treatment for rhythm control in patients with atrial fibrillation. Catheter ablation can restore sinus rhythm and is superior to antiarrhythmic drugs. In symptomatic patients with atrial fibrillation and heart failure with reduced ejection fraction, catheter ablation has reduced heart failure hospitalization. The guidelines recommend that patients receive an anticoagulant for at least 3 months after catheter ablation, and the decision to use long-term anticoagulation should be based on CHA2DS2-VAS score. Antiarrhythmic drugs. Oral antiarrhythmic drugs are commonly used to prevent episodes of paroxysmal and persistent atrial fibrillation and to maintain sinus rhythm after cardioversion, catheter ablation, or pharmacologic conversion. Amiodarone. It is the most effective antiarrhythmic drug for maintenance of sinus rhythm. It can be used in patients with heart failure with reduced EF. It has a long variable half-life of 40 to 55 days. Dosing. It is given in a dose of 200 mg twice daily for 2 to 4 weeks, followed by 100 to 200 mg once daily. It can be given intravenously in a dose of 150 mg over 10 minutes, followed by 1 mg per minute for 6 hours, and then 0.5 mg per minute for 18 hours, and then oral maintenance dosing. It comes with serious adverse effects. It can cause prolonged QT interval resulting in Torsades de Pointes. Long-term adverse effects include pulmonary toxicity, hepatotoxicity, hyper or hypothyroidism. Dronedarone is a non-iodinated analog of amiodarone and is less effective than amiodarone. It is given in a dose of 400 mg twice daily. Comes with severe adverse effects which include pulmonary toxicity, hepatotoxicity, worsening heart failure with increased mortality, and prolonged QT interval. Flecainide and propafenone are generally reserved for patients with structurally normal hearts. Flecainide is given in a dose of 50 to 200 mg twice daily. Propafenone is given in a dose of 150 to 300 mg every 8 hours. Both of these medications can cause adverse effects such as bradycardia, AV block, sustained ventricular tachycardia, QT interval prolongation resulting in torsade de pointes. Sotalol is a non-selective beta blocker which is given in a dose of 40 to 160 mg twice daily. Adverse effects include QT interval prolongation and torsade de pointes. Rate control. Ventricular rate control is an acceptable management strategy for patients with paroxysmal or persistent atrial fibrillation. It can be achieved with beta-adrenergic blockers, calcium channel blockers, digoxin, and amiodarone. Beta-adrenergic blockers such as atenolol, bisoprolol, carvedilol, metoprolol are often used for long-term rate control. Beta blockers are preferred over calcium channel blockers in patients with coronary artery disease or systolic dysfunction. They should be used cautiously in patients with asthma or decompensated heart failure. Atenolol is given in a dose of 25 to 100 mg once daily. Bisoprolol is given in a dose of 2.5 to 10 mg once daily. Carvedilol is given in a dose of 3.125 mg to 25 mg twice daily. Metoprolol is given in a dose of 25 to 400 mg divided twice daily. It also comes in extended release version called Toprol XL, which can be given once daily. Some adverse effects of beta blockers include bradycardia, hypotension, cardiac failure, fatigue, depression, and worsening of peripheral arterial insufficiency. Calcium channel blockers. Oral non-dihydropyridine calcium channel blockers such as diltiazem and verapamil may be preferred over beta blockers for long-term rate control in patients with asthma. Diltiazem, given in a dose of 120 to 480 mg divided 3 times daily or 4 times daily. It comes as an extended release known as Cardizem CD, which can be given in a dose of 120 to 480 mg once daily. Verapamil, given in a dose of 120 to 480 mg divided 3 times or 4 times daily. Some adverse effects include bradycardia, hypotension, AV block. Digoxin. Oral digoxin remains a second-line treatment for rate control, especially in patients with heart failure with reduced EF. It is given orally in a dose of 0.125 to 0.25 mg once daily. Intravenously, it can be given in a dose of 0.25 mg and can be repeated every 6 hours to a max of 1.5 mg in a 24-hour period. Some adverse effects include bradycardia, AV block. Long-term use can result in abnormal vision. Amiodarone, more often used as a rhythm control agent. IV amiodarone has been used for ventricular rate control in critically ill patients.